What's up, everyone? Welcome to another episode of Radiopedia's Friday live streams. For those new to our videos, these live streams are in support of our upcoming virtual conference, Radiopedia 2023, which will run from 24th through to 28th July. Over the next few months, my fellow conference convener Vikas Shah and myself will be bringing you some incredible talks from our lecture collection. And we're glad that you're joining us, whether watching and chatting live or catching up at a more convenient time. Registration for the conference is now open and free for people in the 125 low and middle income countries. Otherwise, if you would like to know more on the conference registration pricing, whether tiered or concession, just head on over to the main conference registration page itself after watching this live stream, of course. Purchasing the main conference access will also give you a 1-year-long all-access pass, which will let you view a huge amount of our exclusive materials, such as our learning pathways and an extensive lecture collection. So I think this is a pretty amazing bargain. Also, just an update regarding our brand new R poster feature. We've had an overwhelming response to our call for abstracts, and our team of expert reviewers are now working through them. So do keep an eye on your inbox for news on whether your abstract has been accepted. Right, let's get to our featured lecture. I'm really excited to introduce our speaker, Andrew Murphy. He's a radiographer from Brisbane in Australia, managing editor at Radiopedia, and also my mentor and friend. Andrew's talk is titled X-ray Interpretation of Foot Injuries, and as you watch, you'll realize that he has a way of breaking down the really complex concepts. I hope you enjoy this lecture. I find that I always learn a lot from Andrew. If you've got any comments, questions, do drop them in our live chat box. Andrew, please.
Hi, my name's Andrew Murphy. I am a radiographer in Brisbane, Australia, and a managing editor for Radiopedia. Today, I'm going to be talking to you about why we should never play competitive sport again, why we should always wear shoes no matter where we go, and never get in a car or ride a bike for the rest of our lives. We're going to be looking at injuries of the foot and the radiographic interpretation of those particular presentations. So the bulk of our talk today will obviously be about cases that we see in our day-to-day work, but we have some introductory stuff that we want to get out of the way first. So let's look at the anatomy. So the foot is made up of 7 tarsal bones, 5 metatarsals, and then your phalanges and distal phalanges. The bones are named, quite intuitively. The square-looking bone on the lateral aspect is called the cuboid. The upside-down boat-looking thing on the medial aspect is called the navicular. You have your medial, intermediate, and lateral cuneiforms, and then obviously you have your talus and your calcaneus. The 2 major joints of the foot that are worth remembering for this talk are the tarso-metatarsal joint, which is also known as the Lisfranc joint, and the transverse tarsal joint, also known as the Chopin joint. Now, why they are important is they break the foot into 3 sections. They break it into the forefoot, the midfoot, and the hindfoot. And that's what we're going to break our talk into today. We're going to start with the forefoot and end with the hindfoot. Now, before we get into cases, it's really good to know, variations that can mimic abnormalities as they catch you out straight off the bat. So here are some of the more common accessory ossicles and sesamoid bones that you can expect to encounter, on top of obviously your classic sesamoid bones at the first metatarsophalangeal joint. Now, you don't have to memorize these. It's good to know where they kind of are, but you can look them up if you suspect that you see one on Radiopedia. The key to differentiating these from a fracture is obviously knowledge that they exist in that region, the clinical picture, as well as looking for smooth cortical edges of the bone. 2 variations that catch a lot of people out is the apophysis of the base of the 5th metatarsal. Note how it runs along the bone and not traversing it. That's very important, along with obviously the clinical history. And the other is the os peroneum, which is a small sesamoid bone located in the peroneus longus tendon, and it sits really close to the cuboid and can often be mistaken for a avulsion fracture. But if you look really closely, look how nice and smooth those edges are here, and there doesn't seem to be any donor site at the base of the fifth metatarsal there. Now, the radiographic series for feet, it's very varied, very departmentally dependent. It depends who your orthopedic surgeon is. We won't get into every specific view because I think that's not very useful, but we'll just go with what are the basics. So your standard series is, your AP, oblique, and lateral. It's always good to do these weight bearing if you can. The foot is a weight bearing structure, so you want to be showing the foot in its true functional state rather than not. But that is patient dependent, departmental dependent, and equipment dependent. If you want to look at the toes, you want to do a dedicated toe series rather than doing the entire foot. If you want to look at the calcaneum, you need to do this lateral view. It's nice and coned in, and an axial view to see if you can elucidate any articular involvement. It's a tricky view, and it's going to depend on how much penetration you get through those soft tissues. Now, speaking of soft tissues, any good search strategy should start with soft tissues. What I like to do is park any abnormality that I see and look carefully at the soft tissues for any secondary signs of other trauma. Then I look at the bones to make sure that there's no breach in the cortex or trabecular pattern. Then I'm looking at the alignment to make sure that the joints and everything is congruent and there's nothing in the joints that could be contributing to that patient's pain. And then we have review areas. Now, review areas are often the fringe areas of the case that you don't want to miss. But for me, it's the fringe areas, but it's also the abnormalities that I've missed in the past. So it's the thing that I check at the very end. Okay, I can't see an abnormality, and I definitely can't see a base of fifth metatarsal fracture because I missed one once. And it's a very good way to have that checklist approach at the end of your search strategy. So here's a normal foot. Note that there's no breaches in the cortex, and the soft tissue is quite uniform. And you have these soft tissue, you have these sesamoid bones here at the first metatarsophalangeal joint. It's pretty normal to see, and you can sometimes see some here at the fifth metatarsophalangeal joint. You can fracture these sesamoid bones. It's rare, but it's worth keeping in the back of your mind. But radiographic interpretation of the foot is mostly about alignment. So let's have a look at some of the more common alignment tools that are easy to remember and somewhat useful. So first we have the M1-C1 alignment, which is between the lateral border of the base of the first metatarsal and the lateral border of the medial cuneiform. They should be nice and aligned, and there shouldn't be any kind of step in that particular line, and that's obviously in your DP projection. And then you have that alignment between the base of the second metatarsal and the medial border of the intermediate cuneiform. And again, you want to make sure that there's no step in that particular line, and you'll see why shortly when we look at some Lisfranc fractures. On the oblique projection, you have the alignment between the medial border of the base of the fourth metatarsal and the cuboid bone. Best assessed on the medial oblique view. You're not going to really see that on the DP view. Back to the DP view though, you have the distance as well. So the M1, M2 distance shouldn't be any more than 4 millimeters, which is still a fair bit. The C1, M2 distance, which is that medial cuneiform and the second metatarsal, shouldn't be any more than 3 millimeters. If there's any widening there is a possibility that there's an abnormality, and we'll discuss that further soon. Then you have the C1, C2, which is the distance between the medial cuneiform and the intermediate cuneiform. And, it should, in a normal image, be pretty tight. There shouldn't be much wiggle room there. And then lastly, on that DP, you want to make sure that there's no disruption of the medial column there. Going on to the lateral projection, you're just kind of scanning that dorsal edge here, making sure that there's no breaches in the cortex or any jumps at all within that line. And if you have a keen eye, you could see that is that os trichonome that we talked about on that slide previously. Now, a very handy angle is the Bowler angle when you're looking at calcaneal fractures. And what you do is you join a line from the highest point of the anterior process of the calcaneus to the highest point of the posterior facet, and then you have another line joining the highest point of that posterior articular facet with the highest point of the calcaneal tuberosity, and it should be around 25 to 40 degrees. It's pretty variable, but a reduction in this angle suggests compression. So you have a fracture of the calcaneum that is causing the compression of those structures and a reduction in those angles. So let's start with some forefoot injuries. So the first phalange, also known as the hallux, you have a stubbing toe or a crush type injury. This injury is often overlooked because patients come in late because they stub their toe or they drop something and they don't really think it's a big deal until a few days later. And it often looks something like this. Dedicated toe views, very handy, and you can see here that there is a clear break in the cortex here going all the way through, and it seems to have an intra-articular component as well. You want to be really careful that you are looking at the entire radiograph, and if there is a chance to clinically evaluate them, you want to make sure that they don't have like a nail bed injury as well. Now the phalanges 2 through to 5 is usually the result of being barefoot and catching your toe on like a fixed object, which forces the toe into abduction. So here we have a good example of a crush injury, so dropping a weight onto your foot. And if you look very carefully at the medial oblique projection, you can see that there is a break in the cortex here, and we have a clear impact fracture all the way through, and I can't really see anything else. But when you are looking at crush injuries, you want to be assessing all the structures around to make sure that you don't see any other associated fractures, because something heavy has been dropped and it's broken their bone. Now the majority of these fractures are catching your toe on something, so it looks something like this. You're walking in your living room, you're not wearing shoes, and then you catch your little toe on the corner of something and snap. And you can just feel it by looking at this illustration here. And they can sometimes be quite subtle. Like on this projection here, this person swung his leg and he hit the right door. He hit his right foot on a door handle. Looks kind of weird on this projection. These looks like something doesn't look quite right. You can just see a breach in the cortex here, and it's only when you do these really focused, dedicated toe views like this that you can see that this patient has fractures all the way through. Very hard to see here, but when you look at the proximal phalanges here on that view, there are multiple fractures, and this poor person's caught their foot, and now they're going to probably be walking in a moon boot for quite a while. I guess they won't stub their toe again though. Metatarsal phalangeal joint dislocations, same type of force, heavy aggressive dorsiflexion. So something like this, AP projection looks somewhat normal. You have some overlap here of that joint space. It doesn't look quite normal. It doesn't look like this one here. It's only when you get to the lateral projection that you can see that there is definitely a dislocation of that metatarsophalangeal joint. It's just sitting there by itself with no articulation, which is a good learning point, is that if you take a bad lateral of a toe, just send it anyway, because it actually might elucidate a abnormality that you can't actually see on other views. Or it could look like this, where you have heavy dorsiflexion from a motorbike injury where you're not wearing the right foot equipment, and you have global dislocation of all the joints here. So 2nd through to 5th metatarsophalangeal joints, you have lateral displacement, and they've all been knocked off all the way through. And again, the only real indication on the DP projection is you have superimposition of all those structures, and it isn't until you start doing other views that you can appreciate that there is a significant dislocation event there. So some tips for phalanges. Dedicated toe views are actually really useful. The DP foot it's a good projection, but you can miss things, especially with beam divergence. Presentation can be delayed. People think that they've stubbed their toe, it's not a big deal. Give them a few days, they can't sleep because of the pain, then they go to the emergency department. And you want to be looking for nail bed injuries, especially people who've dropped things on their foot. You want to be making sure that there's no compound fracture compound component to that fracture. If they have a nail bed injury, that has to be, opened up, washed out, and making sure that there's no infection in the bone there. Now, the first metatarsal is kind of a different mechanism. So it's often direct trauma or axial loading with dorsiflexion. So, that is the head of the metatarsal just kind of smashing into the phalange there. It can look like the illustration that I showed, or it can look something like this, where you have this fracture line just hiding with the sesamoid bones here. So you have sesamoid bone, and then you have this lateral corner fracture here, which is a bit of a tricky case, especially if you're looking only at the medial oblique here. This is a really good one for an exam. So it really shows that if you just do a dedicated 4-foot projection like this, it's a lot handier to see that particular abnormality, and it's not going to hide so much if it's on the fringe areas of the case on a DP projection. Here we have a pretty obvious fracture, but it's something that I wanted to bring to your attention, to everyone's attention, and that is that when you have a fracture like this that's transverse and kind of sitting below this arc here, so it's starting to get into that tarsometatarsal joint region, especially when it's intra-articular here, you need to start thinking that this patient might have a Lisfranc injury. We're going to talk about that soon, but any type of transverse fracture, especially below this particular arc here, you need to think to yourself that there is a transmission of force that has gone beyond that fracture line that is affecting the soft tissue structures. Metatarsals 2 through to 4, often direct trauma or a crush injury. So this is the classic, you drop something on your foot and the metatarsals go. This is a really good example of that. Here you have fracture, maybe not. So 2, 3, and 4 are all fractured from dropping a heavy weight on that patient's foot, and you can kind of see it on both projections here. But it's good to know that these particular injuries, they don't happen in isolation, and if you're dropping something on your foot and it's breaking a bone, chances are, unless it was a very small object, it's going to break a few more. So you want to be parking that first abnormality you see and looking for more fractures. Now the 5th metatarsal, you can drop things on it and break it as well, but you're mostly hurting your 5th metatarsal from inversion or torsional type mechanisms. Now, it kind of gets tricky here and people get very confused, including myself. You have 3 main types of 5th metatarsal fractures. You have the spiral fracture, the Jones fracture, and the avulsion fracture. Now, the spiral fracture is your classic extra-articular fracture that has occurred because of a twisting force, the torsional type force, and the shaft of the metatarsal has given way. And it looks, something like this. There is a bit of bony remodeling here. This looks like it's a bit old, but this is the classic shaft fracture of the 5th metatarsal that you would expect to see from a rolled ankle or some sort of very sudden inversion force. And then you have the Jones fracture, which is a metadiaphyseal junction fracture at the 5th metatarsal that involves the 4th and 5th metatarsal articulation. It's not quite an avulsion fracture. And what makes this particular fracture worth distinguishing from the other fractures is you have that peroneus tertius and the peroneus brevis tendons. They pull in kind of alternate directions and they produce this deforming force as illustrated, and it makes the fracture inherently unstable and prone to non-union even if you're not weight bearing on that structure. And it looks something like this. It can look very subtle. It doesn't look that, concerning, but if you understand the structures that are attached to each side of that fracture fragment, you can see that there is going to be this unopposed pull from both sides here, and that fracture is not going to heal without some sort of, immobilization or intervention. And then we have the avulsion fracture, which is sometimes called the pseudo-Jones fracture, which is very confusing. I never call it that. And that is your classic peroneus brevis tendon avulsion fracture here. because of an inversion or torsion type force, and it'll look something like this. And note how it's running across the bone and not kind of running with the bone. That's how you can kind of tell the difference between that and an apophysis. And it's sitting, pretty close to that articulation here. It's not sitting all the way out here, although it can be pulled that aggressively down there. And that's where you want to be checking for, big breaches in the cortex, jagged edges, and there's no smooth lines. So I know we talked about this before. You have the apophysis, you have the os perineum here, which mimic fractures, and it's good to keep those in mind, but sometimes you kind of have a bit of everything. So here, the image on the left, you have an unfused apophysis here, so it's running with the metatarsal, but then you also have a fracture line running across as well. So, it's good to keep in mind that even if you do see the unfused apophysis here, you need to be looking for a fracture as well, especially if you can see, probably not so much on the monitor here, but there is a little bit of soft tissue swelling here, and it would fit the clinical picture of an inversion type injury. And this unlucky individual on the right-hand side has both a avulsion fracture and a Jones fracture. So patient age is really important. Obviously, this patient's a lot older, and clinical history and the area of pain is paramount. But you have here an avulsion fracture, and then you have a Jones fracture running across here. It's very unlucky, but it's a very tricky exam type question. So some tips for metatarsals: always review the base of fifth, keeping in mind those anatomical variations and taking into account the clinical picture. Crush injuries are seldom isolated, so once you see one injury, park it, keep looking, and anything that's close to that tarso-metatarsal region, start considering a Lisfranc injury or anything that is quite a significant mechanism and there isn't as many abnormalities as you would have foreseen. That's when you need to start thinking about that as well. So let's start talking about that. So the Lisfranc injury occurs because of direct force or forefoot abduction or forced plantarflexion. You have your abduction type injury first, and that is where the foot is kind of planted in a fixed position and rotated forcefully, and then you have the foot kind of giving way, so the second metatarsal breaches dorsally, and the lateral column of the bases of the third to fifth metatarsal start to shift in the lateral direction, often impacting the cuboid. This is that classic get your foot stuck in the horse stirrup type mechanism that you would have heard about. That is one of the ways that you can do this. The other way is the forced plantarflexion. So that is where the foot is starting to be plantarflexed on a field or something like that. This is a very sporty type injury, and then you have a significant force axial loading, and then the foot gives way at the tarso-metatarsal joint. Again, the second metatarsal breaches dorsally, and then the lateral column starts to migrate in that lateral direction, impacting the cuboid there. And then obviously you have other ways to do this. So direct force, so getting your foot hit while you're driving a car, can also impact that tarso-metatarsal joint. A lot of different ways to do this injury, but they're some of the more common ways to do it. So the Lisfranc ligament complex is really important. It acts like a stabilizer of the midfoot. So it connects the bases of the second metatarsal with the medial and lateral cuneiforms, and it creates like this keystone configuration, and it locks everything in place. So it's a really key stabilizer of the foot. So you have three components. You have the dorsal ligament in green, which is the weakest, which is always the first to go, the interosseous component, and then the plantar component, and quite variable, the plantar component, depending on where you read. There's a lot of research on this, but it often sends bundles to the second and third metatarsal bases, and you can see how it acts like a very core stabilizer. So a breach of that particular joint complex ends up in like complete instability of the foot, and you have a lot of functional issues, and they have to be addressed. So there are many injury patterns of this particular abnormality. It's broken up into different categories based on congruity of the joint. So you have your homolateral or complete incongruity of all the tarso-metatarsal joints, and it either goes medial or lateral. It looks something like this. Not very subtle. On X-ray, here we go, we can see that the tarso-metatarsal joint is being completely compromised and there are multiple fractures at that particular junction. You have the homolateral incomplete mechanism, which is where you have congruity of some of the tarso-metatarsal joints but not of the others, and this is where it starts to get a little bit subtle. So here we have where the first metatarsal is the only thing that loses articulation, or it might be the only thing that has articulation, whilst all the lesser rays start to migrate in the lateral direction. And it can look something like this, very subtle. The only sign that you might have of a particular abnormality besides slight widening of that M1, M2 interval is this thing called the flex sign, where you can just see there's a little bit of bone that's from the second metatarsal base that's still obviously connected to that Lisfranc complex. And that is a key indicator of a Lisfranc abnormality, and that patient needs to go on to have further imaging to properly show that. And let's have a look at a less obvious case. So here we have a patient who is coming with mid-foot pain. When you're looking at the images here, you can't really appreciate that there is any real widening. You could probably convince yourself because this is going to be abnormal. I wouldn't just show you a normal case. When you look at the bases here, maybe that there is a flex sign within this joint space, but it wasn't until this patient had an CT that you can see that there is a fracture of the base of the second metatarsal here, just at the attachment point of the plantar aspect of that Lisfranc joint complex. So you can appreciate that these can be very obvious, where you have those huge homolateral displacements, or they can be really subtle. So the clinical context and the pain is key to this particular abnormality. And then you can have your divergent type presentations where it's not too subtle, multiple fractures. You will need cross-sectional imaging for this to further elucidate any other abnormalities. You want to make sure that you pick every single one there. And then it gets harder again. You can have midfoot sprains, so not all Lisfranc injuries need to have a osseous component. And this is where people kind of get caught up when they think that they've just sprained their foot, when actually they've done a lot of damage to their feet. Their Lisfranc joint is completely shot and they have instability of their feet. So it can be, subtle to the point of no abnormality at all, just some, inflammation of that ligamentous complex, or you can start to have, ruptures and inherent instability of that tarso-metatarsal joint. So here's a good example. You have midfoot pain. There is widening of that joint space here, that M1, M2. There isn't really any breaches in the line there, but when you do a weight-bearing view, you can definitely appreciate that there is significant widening here in that Lisfranc area. There appears to be a breach of that M1, C1 line here, and it really highlights the impact of functional imaging and why midfoot pain really should be met with functional imaging in the emergency department to make sure that you are not missing these particular abnormalities. So here we have a midfoot sprain and you have complete disarticulation between the C1 and M2 from the Lisfranc complex, and this patient would have to go on to have treatment to make sure that they get this fixed up and they can actually walk properly again. This is quite a debilitating injury, both for just the general public and for professional athletes who have who often do those forced abduction rotation type injuries. So some tips that are worth keeping in mind. Functional imaging is key for Lisfranc imaging. Remember the search strategies, remember those alignment points, and remember to assess the joint spaces to make sure that there's no widening. And clinical details are really important. Their pain for Lisfranc injuries tend to be really out of proportion to the injury. So unlike, rolling your ankle, people will talk about the sudden pain that they're in, they almost passed out or they almost threw up, their body has this visceral reaction, and that's really a good way to remember that this patient might have a Lisfranc injury. So moving on to some other tarsal bone injuries, the cuboid fracture. Occasionally this presents with severe midfoot pain and it will accompany a Lisfranc injury. It's that same mechanism of force, abduction, rotation, and you have the lateral rays or the lateral metatarsal bases kind of migrating laterally and towards the cuboid. And this is called a nutcracker mechanism, and it crushes the cuboid bone and causes an injury. And it can be subtle or it can be obvious, and it can look, something like this. So this is a patient with midfoot pain. They presented to the emergency department. The radiographer flagged that this was an abnormal image. They saw that there was a breach in the cortex of the cuboid here, and then that patient went on to have further treatment, and I believe they went into a moon boot for a while and had a very good recovery. But it was a really good pickup, and it's a very subtle abnormality if you don't know what you're looking for. And again, those clinical details are really important. The navicular fracture is missed a lot, especially in heavy multi-trauma. It takes a significantly high amount of energy to fracture the navicular. You have the navicular being smashed into the head of the talus there, and it looks something like this. So you can appreciate that, a fracture like this, if you have multiple abnormalities, it kind of looks like it should be there, I guess, especially on this projection here, and the laterals, they're pretty difficult to see. So this is a really good, fracture to be looking for, especially in big multi-trauma patients. You don't want to be missing navicular fractures like this. So let's move on to hind foot injuries and start with the talar neck fracture. So the talar neck fracture is when you have axial loading on a foot that's in a rigid position. So, your foot on a motor pedal, your foot on the accelerator or the brakes when you're driving, and it's axially loaded, and it impacts, and you have this heavy dorsiflexion of the foot, and it causes a break in the thinnest part of the talus, which is the neck. It's broken up into 4 different categories called the Hawkins classification. Undisplaced fracture is type 1. Type 2 is a displaced fracture with subluxation or dislocation of that subtalar joint. Type 3 is a displaced fracture, but the body of the talus is dislocated from both the subtalar and the ankle joint. And then type 4 is a category which is quite rare, but you have dislocation or subluxation of the head of the talus at the talonavicular joint as well. The type 1s can be really subtle, and you might only see them on the oblique foot. So it's good to do a foot and an ankle when you are looking at these particular injuries. If you suspect them, you could argue that there's a breach in the trabecular bone here. Pretty hard to see. When you look at the oblique projection, you can definitely appreciate that there is definitely an abnormality here, and that is a type 1 talar neck fracture. Type 3, not so subtle. So you have displaced fracture of the body of the talus, dislocated from both the subtalar and the ankle joint. It's important to note that, a lot of energy has, gone into breaking this bone. So there's going to be other injuries. Good example of this projection here is that you have this first metatarsal fracture here. Because you have that first metatarsal fracture here, and it's pretty close to that tarsometatarsal joint, there is a chance that there is going to be a Lisfranc injury associated with that as well. The posterior process fractures of the talus, very rare, often looks like an ostrigonome, which is that developmental failure of the posterior tubercle. What you're looking for here is first clinical context, axial loading or some sort of ankle pain, midfoot pain in the posterior region. Donor site, you can see here there is a break in the cortex here, and it correlates very well to this osseous fragment just here, and there is a bit of soft tissue swelling associated with that as well. If that patient has had imaging before, you can compare the old imaging to make sure that that isn't a accessory ossicle, but you can tell from looking at this image here that that is an abnormality. It's good to know these exist. They're very rare, but you'll look like a champion if you pick it up. The lateral process fracture of the talus, pretty rare, often only seen in snowboarders. So it's this forced eversion, externally rotated foot, but has to be loaded. So you have to have the foot in kind of like a very tense position as if you were snowboarding. So it looks something like this. Pretty tricky. When you look at the AP ankle here, you can just see that there is a breach in the cortex here. There's an osseous fragment being pulled away from that lateral process, and that is a pretty hard fracture to to spot. It has a huge intra-articular component that is often underappreciated on X-ray. The patient needs CT to further delineate that injury. And yeah, pretty difficult to see in the clinical history. It'll help if they're a snowboarder, definitely look for these, but kind of keep this in the back of your mind when you're looking at radiographs, maybe one of those check areas at the end, making sure that you're not missing it. So some tips for the talus: foot and ankle views is the best way forward. You're going to miss something on the foot view, you're going to miss something on the ankle view. Doing both for this abnormality is very handy. The mechanism is really, really important. If it's a high velocity mechanism, you need to start looking for other fractures. Those talar neck injuries are seldom isolated, and you're going to have significant abnormalities and often a soft tissue component that accompanies it. Calcaneal body fractures, pretty obvious a lot of the time. Extreme axial loading, jumping from a height, falling onto your feet. Devastating consequences for the patient if they're not treated properly. Really huge implications for their quality of life. 10% of the time it's bilateral, especially if they're falling from a height. You need to start thinking about axial loading and what else could be broken. The patient might have a spinal fracture as well. So it'll look something like this. You have that decrease in that Bowler's angle here. Then you do the axial projection and you can appreciate if there is an intra-articular component or not. And it's quite a flat looking calcaneum, right? You can't even trace those lines that we were tracing before in that diagram. You can get a subcategory of calcaneal fracture, the tongue type fracture, where the Achilles tendon starts to rip away an aspect of the calcaneum. It'll look something like this. You can get these beak type fractures as well, which are significantly more impressive, where it kind of like that, and it'll have a soft tissue component that you need to take into consideration when you're looking at these abnormalities. They can get compartment syndrome, and they need to have that addressed immediately. Some calcaneum body tips, check both feet. These are often bilateral, often kind of stretch 10% bilateral. Consider the fact that they could have a spinal fracture, especially if they've fallen from a significant height and had that resultant injury to their feet. And there is a pretty high risk of an open fracture, again, taking into account that patient's mechanism of injury there. Now, the anterior process fracture of the calcaneum is this flexion inversion injury, and it's one of those check areas that you should be making sure that you review at the end of your case. Very subtle. It's this avulsion fracture of that bicunate ligament, and you can just see it here. You can just see this abnormality here when you look at this lateral projection. It's a very small fracture, but it has quite wide-ranging implications, and it can be indicative of a bigger injury. And that is a mid-tarsal sprain, which is a lateral column distraction-related avulsion fracture series of injuries. So you have that anterior calcaneal process fracture of that bifurcate ligament, dorsal calcaneo-cuboid ligament avulsion, and then you have these impaction fractures of the navicular bone, and sometimes you can get talar head fractures as well. Very subtle. So it'll look something like this, which looks, somewhat normal. You can see that there is a fragment immediately superior to the navicular bone here. It's kind of hard to appreciate unless you point it out, that you can't really miss it after that. That's an avulsion fracture. When you look at the medial aspect of that anterior calcaneal process on the oblique view, you can appreciate that there is a very subtle avulsion fracture here. And then when you go onto the DP projection, you look lateral to the cuboid bone, there is a very subtle area of abnormality here. When you go on to give this patient an MRI, which this case is fantastic, they have tears and avulsion fractures everywhere, and they have a significant mid-tarsal sprain, and that patient will have inherent instability of their feet. This is very similar to a Liz Frank injury. However, it's very underreported because it's so subtle. So some tips for when you see these particular injuries, especially that anterior process avulsion injury: check for further abnormalities, making sure that you're not missing any further avulsion fractures. You need to start thinking about a mid-tarsal sprain. Often this is mistaken for an ankle sprain, so you might want to go on to cross-sectional imaging if you have specific concerns that that patient might have inherent instability of their tarsal bones. So we're going to finish off with some dislocations. So you have the subtalar dislocation, which is a talonavicular talocalcaneal joint dislocation, but there is often no fracture associated with it. Pretty hard to miss. They're very difficult to image on plain film, and you want to be looking for associated fractures. But yeah, this is a very obvious abnormality and just a challenge for the radiographer to image. And then finally, we have total talar extrusion or dislocation, which is a triarticular dislocation of the talus at the tibular talar, tibular navicular, and the subtalar joints, and it is completely taken out of the joint. So this is that once in a year trauma that you get where the patient comes in and the talus is kind of not either with the patient or it's in their shoe. It's a huge compound component to it. Obviously, this patient has significant injuries other than this particular one. Huge risk of avascular necrosis, which is the least of their issues, but it's worth knowing that these exist. If you can't find the talus in the x-ray, look in the patient's shoe when they come into the multi-trauma bay. And that's it. So I hope that you've learned something today, and I think that we all know that the most important takeaway from this talk is to always wear safety shoes and never get in a car again or play any sport where you can invert your ankle, because there are a lot of ways to hurt your feet and none of us want to do that. Thanks a lot.
All right, how was that? Thank you, Andrew, for that insightful talk. I just wanted to mention that Andrew spent several hours, about 40 hours actually, specially creating all the illustrations that you saw in his talk, so you can imagine his dedication. If you enjoyed that, Andrew actually has an extended version of this via his foot and ankle learning pathway, which you will be able to enroll in with an all-access pass. Additionally, you won't want to miss out on Andrew's brand new lecture for Radiopedia 2023. It's titled Top 10 Commonly Missed Extremity Fractures, and that is one of 5 brand new musculoskeletal imaging lectures on day 4 of the conference, alongside 3 other brand new spine imaging lectures too. It'll be an MSK feast. So that's all we have for now. Don't forget to check out the conference registration page for pricings, and also to have a look at the entire conference program. Going off of today's talk, you already know that we strive for the highest quality. And so at Radiopedia 2023, we will be bringing you the best speakers, beautifully crafted videos, crispy audio, and English captions for all lectures, in addition to a ton of review questions. Alright, that's all for today. We'll see you again soon for another live stream. Take care and goodbye.